I'll start with the easier of the questions, which is oligometastatic progression, especially in the brain, where we may or may not be seeing full penetration. There's lots of data that shows that EGFR TKIs do get some sort of CNS penetration, but it's clearly not the full amount of penetration that you're seeing outside of the CNS. So if somebody has a new brain met when they're on erlotinib, or crizotinib for that matter, I generally hold the drug, I give them their whole brain radiation, or I give them stereotactic radiation, and then go back to what I was doing. If somebody has oligometastatic relapse in another location, say a new lung nodule, a new adrenal nodule, solitary bone met, something like that, again, I'm likely to try to use what I call spot welding, some radiation here or there to try to get that patient through, because the longer I can milk a particular therapy, the better I think it is, especially, again, if they're tolerating it well. With regards to more systemic progression, where it looks like I'm actually starting to see failure of the drug that I'm using in a more diffuse setting, right now I'm a little bit handicapped in that if I choose to add a second treatment, it may or not be paid for to continue the first treatment. I actually have to write a letter to the government saying that this is why I'm looking to move on to the next type of treatment, and they actually make me say in the letter that I'm going to be using it as monotherapy. I haven't seen what happens if I try to argue that point yet, because most of the time I am looking to use whatever I'm doing as monotherapy. But right now I'm not combining it because patients will have to pay for it out of pocket, and that can be prohibitive for many patients, especially in the region in which I practice.